More than 87.8% members of the British Ophthalmic Anesthesia Society use this technique in their routine practice. So why the Sub-Tenon block has becoming so popular lately? The Sub-Tenon block is a choice of method in local anesthesia, which has become more popular recently. It provides good akinesia, better intraoperative analgesia, with 50% reduction in posterior capsular tear or vitreous loss, and can be given after an inadequate retrobulbar or peribulbar block. The tenon capsule anteriorly lies in close opposition to the conjunctiva and fuses with it at the level of the limbus. It extends posteriorly, surrounding the globe and fusing with the dura of the optic nerve. The subtenons or episcleral space is a potential space between the capsule and the sclera. The injected local anesthesia into this space diffuses posteriorly into the retroorbital space to block the transversing sensory and motor nerves. The indications of Sub-Tenon block include cataract surgery, strabismus surgery, vitreoretinal surgery, optic nerve fenestration, delivery of drugs around the globe, and post-operative pain relief. While the contraindications are patients that refuse after careful counseling, local sepsis, trauma or perforated globe, grossly abnormal coagulation, severe reaction, allergy or other complications of local anesthesia, confusion, which unable to communicate or to comply with instructions, uncontrolled tremor, inability to adopt acceptable positioning in patients that underwent glaucoma filtration surgery. % lidocaine alone or mixed with bupivacaine with a total volume of 2 to 5 ml can be used as the anesthetic drug. The recommended Sub-Tenon cannula is a 2.54 cm long, blunt, and curved posterior metal Sub-Tenon cannula, which is the 25G. Visco or lacrimal cannula can also be used as an alternative. Topical anesthesia is then given, and clean the anesthetized conjunctiva carefully with povidone iodine. The rest of the orbital margin can then be cleaned with the remaining solution. Eyelid speculum is inserted later, and then ask the patient to look up and out. This will assist in exposing the infranasal quadrant to gain access to the space under the tenon capsule. A small tent of the conjunctiva and tenon capsule is raised approximately 5 to 10 mm from the infranasal limbus and can be as inferior as the fornix depending on the patient anatomy. A small incision is made in the tissue using Westcott anatomy scissors, exposing the sclera below. The blunt-ended Sub-Tenon cannula can then be inserted and passed posteriorly following the curvature of the globe. The onset of analgesia is usually rapid, whereas maximal akinesia may take up to 10 minutes to develop. If conjunctival insufflation is noted, the cannula is likely simply in subconjunctival space. And if this occurs, one may need to either reposition the cannula to a deeper plane or possibly repeat the tent and snip as described before, to expose the true sub-tenon space. Although rare, complications that can occur include subconjunctival swelling and subconjunctival hemorrhage, which can be resolved with gentle orbital pressure, and also conjunctival hemorrhage that can be seen in patients on anticoagulation or antiplatelet therapy.